Welcome to the American Jail Podcast. I'm Chris Daniels, AJA's Executive Director. Today is episode 10 of our podcast, and we are focusing on interdisciplinary leadership, reducing risk and suicide in your jail. Obviously, a very important and serious topic for every jail in the country. I have two subject matter experts here with an extensive background on this topic that I'd like to introduce. I'm just going to straight up read from their bios because they're so long and impressive. First, joining us today is Dr. Ashley Brinkman. Dr. Brinkman has 15 years of experience in behavioral health and holds a broad perspective on intersecting systems in the field, including integrated health operations, clinical considerations, and a patient-centered approach. Through her work as a licensed professional counselor, having seen the role the criminal justice system played in her clients' recovery, she developed a passion for correctional health care. As a correctional health care leader, she advocates for integrated care with low barrier access, placing an emphasis on principles of harm reduction and expansion of mental health services, all accomplished through collaborative efforts between correctional leadership and community providers. Also joining me today is Fred Meyer. Mr. Meyer works with health custody and leaders nationwide to provide detention and correctional facilities with the support needed to operate effectively and in compliance with nationally recognized healthcare standards and applicable laws. He manages a large team of experts on health system assessment, performance improvement and monitoring, suicide prevention, medication-assisted treatment, interdisciplinary collaboration, court monitoring, education, and training for custody and healthcare personnel. Before joining the National Commission, Fred served as Deputy Chief of the Las Vegas Metropolitan Police Department, where he oversaw the largest jail system in the state of Nevada, and he currently sits on the board of directors for the American Jail Association, and he is, in fact, a very active member of our board. So welcome, Fred, and welcome, Dr. Brinkman. If you could, starting with Dr. Brinkman, tell us a little bit about what you're currently focused on.
Sure. So I left the correctional system as a health services administrator, and since then I have been working as a consultant to other facilities, adult facilities so far, and I also do some continuing education for counselors and other behavioral health professionals.
Okay, thank you. And Fred?
Thanks so much, Chris. It's our pleasure to be here. I had as you said, I had the privilege of working for the Las Vegas Metropolitan Police Department for a long career. Retired after running the jail out there in Las Vegas for several years. And I really have been blessed to be able to move into the position I'm in now. It's a nonprofit company that is associated with the National Commission on Correctional Healthcare. And we have a team of experts, doctors, nurses, mid-level providers, custody experts, architects, pretty much everything that you can think of related to jail operations and healthcare. Work from coast to coast, literally from Alaska to New York, from Michigan down to Texas, and really have an opportunity to go into jails, prisons, and juvenile detention facilities with these experts, look for gaps, areas of risk for the agency. Certainly, our focus is on ensuring that a constitutional level of care is provided to those individuals that are in custody. But also beyond that, the effective care really makes it a better environment for everyone there, including the folks that are working in the facility, right? If people that have both medical and especially mental health challenges are receiving the treatment that they believe they should be and are getting effective treatment, it makes them much less likely to act out. Certainly, a risk of in-custody deaths go down, and it's really with a thought to a holistic look at every one of these operations to include the people working there, the most important people, really for us with the American Jail Association, and those individuals that are being held in the care, custody, and control of our various entities across the nation. So this class kind of came about because when we go into different agencies, we see different challenges across the nation. There are some that are the same everywhere, right? But a lot of times it's tough if you grow up in an organization to be able to see some of the gaps that may exist. So we go in, we do these analyses and make recommendations and work with agencies to improve their operation, reduce their risk, and ideally improve healthcare for everyone involved. So it's really our privilege. I've had the privilege of working with Dr. Brinkman on many occasions, and actually I think probably going back to 2022.
Yep.
On the East Coast, we did some work, and really, I really see the impact of mental health both in my prior role in corrections, as well as now seeing it on more of a national scale. So it's our honor to be here, and we're really looking forward to talking with you, Chris, and as well as answering questions that anyone may have.
Thank you, Fred. Yeah, and I'm certainly very appreciative to have someone of your caliber and Dr. Brinkman as our subject matter experts today. Obviously, a very important topic. It has a significant impact on all of our jails. So let's start by talking a little bit more about what you started to get into, and that are some of the common challenges that folks face in custody and health services. One that comes to mind for me, just because I feel the pain of a lot of our nation's jails in this area, and that's staff shortages. What are some of the challenges that contributes to this situation?
Sure. On the custody side of the house, we all know it's really difficult to find staff. I don't know that I've ever come across a facility that's 100% staffed the way they should be. There's a myriad of reasons for that. Obviously, I'm not going to get into all of them here, but needless to say, it seems, the perception is, and there is a lot of truth to it. And I'll have Dr. Brinkman kind of talk about the acuity levels and the kind of the population that's being managed now. But certainly it seems as though over the last 10, 15 years, we're always expected to do, more with less. At the same time, we've professionalized corrections to where the training is much better than it had been in the past. And so certainly staffing is a challenge on the custody side. And this really is something where interdisciplinary leadership comes into play. So Dr. Brinkman, can you kind of talk about what you see on the medical mental health side of things?
So it's a really difficult field for recruiting and getting all of the professionals that you need to have, because one, we're not very good at telling people how wonderful it is to work in the correctional healthcare side of healthcare. So people don't grow up to be a nurse and a counselor and a doctor thinking I want to work in a jail. But it really needs to be an area that we talk more about, so that people can really see that when you join the profession to make the impact that we usually join the profession for, jails and prisons are really where we're needed the most. And that's how I found the field to begin with, is I followed my patients. When I couldn't make progress in other environments, I decided I'm going to go somewhere else that can make a bigger impact. And I think a part of that has to do with the field itself is evolving. We have a field where the communities don't have all of the tools that they need to manage behavioral health issues. So when treatment isn't available, most of the time we end up finding them in incarceration. So that's where you come to find, that over 3/4 of our jail population are now experiencing some kind of behavioral health issues that they need some treatment for.
Yeah,
Just to
thank you,
piggyback
Dr. Brinkman.
off of what, sorry.
Yes, go ahead.
I just wanted to piggyback off of what you were saying, Ashley, that, and you'll see us as we go along, there are so many commonalities with custody and medical mental health. And we really kind of face the same challenges, right? And one of the goals is, at the end of the day, for everybody to go home safe, right? As well as provide treatment. And eventually people are going back to the communities. So while they're in custody, obviously we want to provide them with the best care that they can receive. And very, very interestingly, in my opinion, and the things that I've seen, it's really pretty common that folks, especially with mental health needs, serious challenges, when they come into a jail, they'll actually receive treatment that in many ways is over and above what you get out in the community sometimes. And, some of that is structural, some of it is required. You have, obviously you have to have a constitutional level of care. We all know Estelle versus Gamble and things like that. But when you come in and you're getting that evaluation right when you come in the front door, and identifying those people that need help. And Dr. Brinkman is 100% right. This population, you're never going to find a sicker population. You know, when I was on the custody side of the house, I know it was 100%. They're either going to be here, they're going to be in the emergency room, or they're going to be in a psychiatric hospital. It seems like you get a lot of folks that kind of cycle through there over and over. And one of the areas where really I believe it's under-recognized how challenging it is, but also under-recognized for the treatment that's actually provided to those people that come into our nation's jails. It's suicide is a horrific issue, and it's really always been a challenge for us. But all things being said, and we'll get into the things that you can identify and improve your operations and reduce your risk coming up. But in a lot of cases, when you go to these jails across the nation of all sizes, certainly some are better than others. Some of them are professional than others. Some of them have better trained staff. Some of them have more challenges. But all in all, that care that they receive coming in frequently, I have found is in my opinion and based on my experience, sometimes more effective than what they're receiving when they're out in public. And Dr. Brinkman, I would welcome if you had any feedback on that.
Well, I think it changes the game when you have staff available almost 24/7, if not 24/7. So when staff are there and able to see things that the public healthcare system can't see, we don't out in public, we don't have someone living in the home reporting back how someone's functioning. So we get into the nitty-gritty and find things sooner and intervene sooner, mostly just out of the structure of what incarceration is.
Right. And I wanted to go back to something you said earlier, Dr. Brinkman. It is a very rewarding career, right? To pursue, whether you're on the health services side or the custody side, the people who've devoted their careers to corrections, as both of you have, is in fact very rewarding, but it is also challenging and stressful, right? And especially in a situation where not only are you dealing with a population that does need support around mental health issues and substance abuse issues, but it seems like even more and more so, over time. And so just if you could talk a little bit about some of those demands with the challenges and stress that you're certain to have to work through to help these folks, that would be great.
I think it's important to recognize just the nature of our field is traumatic. From a behavioral health standpoint, everything that we experience as staff and for the people who are in our care, it's a trauma experience. And I read something really powerful for me was someone had said, if you don't come to jail with trauma, you will leave with it. So not necessarily saying that we cause this intentionally, but when you remove people's abilities to function because you're incarcerated in the way that they function in the real world, human nature kicks in and we start to find ways to adapt, whether that's healthy or not healthy ways. So for the staff or for other people who are maybe not as experiencing the intense mental health issues that some of our incarcerated do, we're watching someone go through a really difficult time in your life. There are very few experiences that match what it is to be incarcerated. So when you're dealing with that, it has to be, just like on the airplane, you have to put on your oxygen mask before you help others. The staff have to really keep it at the forefront of caring for themselves so that we have a culture of caring for one another in a jail. So I know that was a little rambly, but it really gets to the point of what it is to be human. We're wired to find connection and to find meaning in our life. And when you're incarcerated, those two things are cut off. So we have to adapt somehow.
Fred, anything to add?
I appreciate what you were saying, actually, especially when we're also talking about the staff that are inside the jail, because they're experiencing all those same events and being involved in some of them. I mean, and this is for both custody and medical and mental health. if there is a suicide, if there is some kind of if there's a homicide, God forbid, medical emergencies happen fairly frequently, disorder. There's a lot of stressors that are really unique to jails. Even when you compare them to prisons, jails are much more like an emergency room versus prison. I would say it's more like chronic care on the medical mental health side, and it's a lot more stable versus jails where you're getting people directly off the street that very often are in crisis. They may be on some kind of substance and emotional crisis and everything else. And that's one of the reasons why Ashley and I have done classes in this area, because it is so critical for custody and medical and mental health all to work together, because they can almost act as force multipliers. Because if we're all heading toward the same mission and goals, and there's collaboration and cooperation at all levels, it has to start at the top, and it has to be at all levels. You can get a much more effective operation. And, I know one of the challenges that we've seen throughout the facilities that we work in is when you have a silo effect and there really isn't cooperation or collaboration to the level that it needs to be with custody and medical mental health leadership. Those are some of the places that you really have the challenges. And I can say candidly, and again, this is my personal opinion, just based on the things that I've seen across the nation over the last 10, 15 years, it's been improving dramatically, the communication, the collaboration. And if there was anything good to say about COVID, I think that's one good thing that could be said. I think that kind of forced a lot of corrections professionals to really evaluate how best you can really manage a large institution or any size institution effectively, and you need to be hitting on all cylinders and working in a collaborative environment. So, but yeah, I really appreciate the fact that we're focused not only on the population that is incarcerated, but also those people that are charged with not only providing care, custody, and control, but everyone there. I mean, there's, your vendors and everyone else that's in that facility is exposed to those traumatic events. So I thank you for that, Dr. Brinkman.
Yeah.
Yes, and there's also, in addition to the incarcerated individuals and everyone who comes together as a team, there's obviously the loved ones who are still in the community, right? And with that comes a tremendous amount of scrutiny and high expectations. And so there's also managing that piece of it. And that's obviously important and brings additional pressure to bear on both the custody and the health services side. Could you talk a little bit about that?
Sure, absolutely. Dr. Brinkman, did you want to go first? Otherwise, I can.
Oh, sure, sure. I think that when you start talking about the only healthcare that is constitutionally guaranteed, there's going to be scrutiny, because there's a lot of opinions that come with when something is required, how it's done, how operations, both custody and healthcare, provide these services, and whose responsibility things are. Ultimately, it doesn't matter whose responsibility it is. We have a parallel a mission. So we have to care and maintain custody within the facility. So I do think that when it comes to those opinions that come from, whether it's loved ones at home, stakeholders in the community, then we have to find a way to identify everyone's priorities so that we can be working toward those same objectives. And if we're not working well with the community and those stakeholders, then that definitely impedes our ability to be effective and efficient inside the jail.
Yeah, I wholeheartedly agree, Dr. Brinkman. The places that I've been, and we do work with facilities that are under consent decrees, settlement agreements. So we do inspections even of facilities, federal, state, local facilities. And one of the things that we found is really, really effective and helpful when you're building those relationships with the community and really getting people to understand what happens behind the walls, because it is somewhat of a closed environment, right? People can say the culture can be a tough nut to crack. Is when people are exposed to what really happens. We're in the age of instant social media, and if something's not a crisis, it's not news, right? I really think that the more that you can invite even those people that are critical of the operation to come in for a tour, really talk to the people that are there, that are doing this job. The vast majority of all the operations and people out there are working their hardest to do the best that they can to provide care and custody for these individuals. Not to say that people don't do things wrong. Of course, it's humans. There are going to be humans that are going to follow the rules, and there are going to be some humans that don't. So you're never going to have perfection when humans are involved. However, when you really look at the operation and what a tough operation it is, do more and more, be professional, provide effective care. You have not the best staffing at most facilities, and you're scrutinized pretty much more than anywhere else in the criminal justice system. I will say that, in my experience, or if you see things in the news, I get a news blast every day from what's happening in jails across the country. It's never positive things. Positive doesn't sell, but so you see these articles come across, but the vast majority that happens in there is good. It's done right. It's appropriate. People are receiving care. You only hear about the negative. So certainly I would encourage everybody out there. And if you are not willing to bring people into your jail and show them your operations and be transparent, there's probably a reason for that. And it may not be a good reason. You may need to really take a critical look at yourself. And so that's part of what we'll talk about as well, because there's some simple things you can really do to avoid conflict, to really get people to understand the operation, and to reduce your risk. And part of that is being open to not necessarily criticism, but taking a critical look at yourself, your own operation, and seeing what potentially you might be missing so you can avoid that in the future. But I know we'll get into that, but yes, absolutely. That's a huge aspect. And again, another area where, and again, I may be biased. I love this profession. My heart is in it. But I would say that truly, there's perception and there's perspective, and I won't get all into that. But what happens in our jail, a lot of the folks working in there, the doctors, the nurses, your officers, deputies, whatever we call, they're not recognized the way they should be for the tough job that they do. So, and it is a privilege to be able to work with all those folks. So, anyway, I'll cut it off there.
Thanks, Fred. And earlier you touched upon communication and collaboration within the walls, and the importance of that. And then Dr. Brinkman talked a little bit about also involving community partners and that communication and collaboration. And certainly that's the hallmark of a really successful program in a community. And so before we moved on, I wanted to just do a check-in and see if there was anything else that you wanted to talk about with regards to communication and collaboration.
Go ahead, Fred.
Oh, so one of the things that I see is when I say it starts from the top, I really mean that. The facilities that we go to where there are a lot of issues, years ago, you would see some people in leadership, well, that's what we pay medical for. We're going to defer whatever, and they really weren't engaged. And what you're seeing more and more now, ever since COVID, and it's getting continually better through even advocacy with the American Jail Association, National Commission on Correctional Healthcare, we see the value of working together as a team. So if you're not having administrative meetings with medical and mental health, you really need to be looking at these things and working together to say, hey, everybody that's getting sent out, did they need to be sent out? Was it appropriate? Every time there's a suicide attempt, well, what really happened here? Let's really look into it, see if we can do a root cause analysis. Is there something we could have done better as an agency working together? Because, and this is where it kind of comes in with the force multiplier aspect of things. Those medical mental health professionals only have a very limited amount of time that they're spending with these people in custody. The officers that are working in those units, modules, whatever you might call them, are with them all day. And if there's collaboration at all levels, you have such a better operation because you will catch things that you would have never caught before if it was just a deferral to that's medical's responsibility or that's mental health's responsibility, things like that. So again, it's changing, and we're really seeing leaders from the different disciplines coming together and having those administrative meetings where they take looks and have committees as well. And I believe Dr. Brinkman will probably talk about this, where they discuss those individuals that really are at risk in many ways to identify the best way to manage them and provide care for them while they're in custody.
I think my favorite example of it is a facility who medical had done a training on how to really dig into process improvement. And one of the administrative leaders said, that training was so good, I'm going to start doing that on our side. And within a year, they had found a way to reduce restraints in their facilities almost by 50 to 100%. It was really high. So when you start collaborating and working together, you're not just communicating on the day-to-day operations, but you're really having this sharing of knowledge that our fields really complement each other very, very well. So if we share the knowledge that we have, then that just increases that efficiency and effectiveness within a facility.
It's a great point, Ashley. And I just had one example I wanted to throw out there as well. A lot of facilities now, even officers have Narcan on their person, right? We have this increasing challenge of people overdosing. When they come in, they either had something in them that they took right before they came in, whatever the case may be. And so you see a lot of facilities with officers carrying Narcan, and there's resistance for them to use it because some people are afraid. They maybe haven't had the training, they haven't used it themselves, are afraid they're going to hurt somebody, it's going to be liability, things like that. And we've had some agencies where we found a lot of great success when you have training, if it goes out via video or briefing rooms or whatever it might be, where you bring people up to instruct on something like Narcan with an officer that has used it to save a life, maybe one of their family members' lives or one of their friends' lives or a person in custody's life. And when you combine that with a medical professional or a mental health professional, they're both working together, the buy-in is incredible, and people are much more likely to use those things, not only at work if someone needs Narcan, but if they're on the street, if it's a family member. And we've seen a lot of success when you can combine that training. So, a lot of times we'll talk about doing man down drills together, any kind of suicide response. These are all really good drills to do together because you don't rise to the occasion, right? You fall to the level of your training. And that's really one of the areas where I think you can really make some gains when you do training in an interdisciplinary fashion where everybody is seeing how that whole situation should go. And then you do like an after action of the training. Hey, what did we do right? What could we do better? Because then when it really happens, you're ready to go.
Mm-hmm.
Thanks, Fred. And so, you mentioned earlier the fact that the media mostly focuses on the challenges that jails are experiencing, right? And the fact is that folks who come to us do need a lot of help, support, and they face a lot of challenges, and they're often at a low point in their life. And so, the fact that they come to us and there's a serious risk of self-harm or suicide is just par for course, right? So let's talk a little bit more about some of the primary causes of death in custody and suicide prevention within jails. If we could shift to that, that would be fantastic. And Dr. Brinkman, if we could start with you.
Sure. So I think it's important to acknowledge, people wonder, why are we still talking about suicide at this stage of the corrections industry? Well, it's because it is still the leading cause of preventable deaths in custody. There's a whole lot of reasons. I mentioned a little bit before about, when humans are disconnected and are also experiencing what they're experiencing, it's natural to focus on those failures that you're thinking of. And then you start thinking about how you've run out of options to manage what you're facing. But when that is kind of the baseline culture that you're seeing, because of the population that we work with, if we allow ourselves to become kind of immune to the severity of what our incarcerated population are going through, that's where the complacency pieces come in. And it becomes normal almost that we see traumatic things on a regular basis. And then we start to respond slower or with less urgency or things like that. And I think that if we address those types of things, we can start seeing some change in what is our leading causes of death in custody.
Fred?
Yeah, absolutely. So mirroring what Dr. Brinkman said, I know for myself, I have seen a lot of my staff when there was an in custody death due to suicide that they struggled. Anytime there's a death, staff will very often struggle because they're processing through that as well. It's a human life, right? And I would say overall, the challenges coming into our facilities, much greater than they were before. It seems like the acuity level is getting high. It seems like every time we come up with some kind of a method to mitigate whatever the drug of choice is, they come up with a worse drug that doesn't work on. And so, I think we're seeing a lot more people. It's critical when you come in, the intake screening, medical mental health, to identify those folks that either should go to the hospital or we need to watch, right? So when they first come in, you're going to see folks that may still actively be on some kind of a substance or in psychiatric truly crisis, that very well may get worse. We see a lot of folks that come in, they start detoxing. And if you don't catch that on the front end, one of these little tips for success, I always have to mention this, Dr. Brinkman hears me talk about it all the time. When you're putting people onto a detox protocol, and they're receiving treatment, they're receiving their, oversight and everything, and you're identifying them as people that are at risk, it's really helpful if you can provide them with some kind of hydration. More than just, hey, there's the tap over there. If you can bring in a Gatorade or some kind of electrolyte drink for those people that are on detox, a lot of times the people that are being sent out, they're being sent out because of dehydration. And that can be really life-threatening, right? Aside from the overdose, just people that are going through detox, it can be absolutely life-threatening. So we've seen a lot of success with folks putting some type of hydration in with the individuals that are kind of on that watch. And I know it can be a little operationally challenging here or there, but believe me, the money you save on one send out is going to pay for whatever it costs you for, to put that in there for a year or more easily. So certainly you have the higher acuity folks coming in that are drunk or they're high and all combinations of things that are just not good, right? That put them at risk, right? Same folks that might go to the emergency room. And then once they're in custody, I think it's critically important when they're in population, those individuals that we have identified a risk with, because, there is a correlation there with substance use, mental health, and suicide risk, right? So it's something where you can't just identify at the front, put them on something, then you want to follow them. And certainly, I think Dr. Brinkman can talk about the folks that are on suicide watch and the importance of follow-up and things like that. And then eventually getting them back to that community is the key, and trying to find that warm handoff. So I don't want to kind of step on all the great information that you have, Dr. Brinkman. Would you mind talking a little bit about that?
Of course. And I think it's important to recognize that one doesn't cause the other. Mental health doesn't cause substance use. Substance use doesn't necessarily cause mental health issues. But it just lends to a perfect storm of situations. So if you're under some kind of influence or going through withdrawal, using some kind of substance, naturally our brains, the way that they operate, are going to increase impulsivity, decrease judgment, and that's where you come up with the solutions that you found to a problem that can be lethal. You may misjudge whether or not something is safe, and it could be suicide, it could be an accidental suicide. And so when those things are correlating with each other, it takes an awful lot of focus to be able to break down what the needs are, what the root causes are, so that they get what they need through treatment. So if we're going and looking at our detox population, mental health ought to be involved in some capacity so that they can look for signs that there is a risk of harm to self, more likely risk of harm to self than others, and see what kind of referrals we need to engage that mental health staff and team. And then also, is it escalating to the point that we need more acute services? And if we need more acute services, once someone's safe and telling you that they're not going to kill themselves today does not mean that they are well and cured. It means that they have come through the worst of it, and they need help rebuilding to get to a point where they can live in our community and be well. So ultimately, the whole crux of corrections is to restabilize somebody to get back to the community. If we're not setting up that plan now in this safe place that you might consider a jail to be, where your meds are available whenever you are scheduled to take them, your meals are coming on a regular basis, you have a safe place to sleep, generally speaking. When those things are able to be put in place and your coping skills occur in jail, and they can be transitioned to when everything's up for grabs. You get to make your decision if you're sleeping in a recovery supportive environment. You get to make those decisions if you take your medications. So if we don't set that up for the community to keep them out of jail, then they just come back. So it is this long, we are one piece of a continuity of care, and we have to recognize that that role and responsibility we hold as a public health entity.
Mhm. Yes, thank you. And you both talked about the importance of screening during entry and continuous monitoring and evaluation once they are in population. And Fred, I understand the National Commission on Correctional Health Care has a suicide prevention guide, right? Could you talk a little bit about that and how folks can access that?
Sure. Absolutely. That can be accessed right on the National Commission on Correctional Health Care website, ncchc.org. And it was a collaborative publication put together, and it really has a lot of great information that have been used by a lot of mid to smaller sized jails to get themselves a suicide prevention program up and running, and one that's going to be effective, because there are some things that are unique to jails compared to everywhere else. One of the things sometimes people don't think about, when you look at the equivalent of target hardening, you're going to look for areas in the jail where someone may have hang points, things like that, lines of sight. And it provides a ton of information as far as when they come in, and it is a document that is written for everyone. So if you take a look at it, it's for custody professionals at all levels, especially, and everything I'm talking about applies especially to those people with boots on the ground, the officers, the nurses that are really the ones doing the job every day, right? Getting it done. And this document applies to everybody at all levels. And I would encourage any of you, go on that website, download it. It's free. There's no obligation or sales of anything. It's a free document that was created that we have worked with a lot of agencies and has a lot of relevant and most importantly, actionable information that you can use to reduce your risk of suicide in your facility. And there's a lot of other ones out there. Certainly, the other thing that I think is important to mention is that what you learn in the document is also applicable to everybody outside as well. It could be applicable to family members and get you thinking about some things that maybe you hadn't been thinking. Because sometimes, this is one of the reasons why it's so important we keep suicide prevention at the forefront, because it affects everyone. I mean, I don't think there's really anyone, very few people anyway, that don't know someone that has committed suicide, especially folks that work in this profession. Dr. Brinkman?
Well, I mean, I was just really getting engaged with what you were saying. I connect a lot with the fact that we're all impacted in some way, shape, or form. Whether it's having been responsive to a code and knowing the officer who had to intervene immediately and save the person, or if it was a coworker that has had a career in corrections and it began to wear on them personally, and then they took their own life. So it is impactful, and if we become too numb to it, that's when we're more at risk.
Thank you. And so, obviously, a key factor in being successful in reducing risk in a jail is going to be disciplinary or leadership, right? And specifically interdisciplinary leadership. and the
Mhm.
culture that's created. So let's shift our focus and talk a little bit about that if we could.
Absolutely.
Fred, would you like to start?
Sure. Yeah, absolutely. My pleasure. This is one of those areas where truly whoever that facility administrator is, they need to be working with the heads of medical and mental health regularly. We have a lot that we work with where they're in communication every single day. It's very, very important. The minimum standards by the commission are for, quarterly meetings with custody leadership and medical mental health. The ones that are effective, they meet a lot more than that. There are a lot of facilities that have meetings monthly. Actually, one of the really well-run, two of the really well-run facilities out there, they have weekly meetings that include all their custody leadership. It includes medical, mental health. There's probably 25 or 30 people around a table. They talk about the challenges that they're having, what's happening in custody, what's the frequency of influenza, what are we seeing coming in the door, how many people we have on detox, how many are going out, how many on suicide watch. And they talk about special cases of people that are having issues and how best to manage them as a team. So those meetings are critical. But what you really need to do, and I'll hand this off to Dr. Brinkman because I know she loves talking about things like this, is it's absolutely a cultural issue. And your success, and I don't want to say failure because you're never going to prevent everything. Bad things happen in jails. They always will. You can't prevent everything. But what you can do is you can mitigate your risk. You can reduce the frequency of things occurring if that culture has a focus of, hey, we're all working together. It's not us and them. It's not something that I'm going to pass off. It's seeing, hey, I'm an officer. I'm having an issue with this person. Let me call medical, that nurse or whoever it's going to be, that, the mental health person. We'll have a conversation. What's the best thing we can do to manage this situation safely and effectively, not only for right now, and there might be some kind of crisis, but for the long term in the facility. And so that culture is just absolutely critical. And it requires everyone at all levels. So Dr. Brinkman?
Absolutely. And I think culture rears its head in really good ways. I know that was a weird metaphor to use, but it comes up in really good ways once you've started to foster that culture. So if you've got those routine meetings that are happening, and like Fred said, the exceptional facilities are the ones that do it more than when the standard says that we should talk to each other, because the people who get to make the decisions, who have the authority to change policy and procedure, if they're not in touch with what's happening with the current population or the struggles the staff are facing, then they can't make the decisions in policy and procedure that are going to support them. So if they're hearing what's a struggle each week, each day, some facilities are meeting every single day to talk about the high-risk populations, then that's when they get to recognize patterns and have the authority to make decisions to change things. For example, one jail administrator that I was working with, as soon as they recognized that their special housing unit was had less frequent rounds than what he had expected them to have, same day he changed the protocol that their officers were going to round with an increased frequency. So when you are able to cut out the middleman of translating and trying to articulate how important something is to the boots on the ground, then the people who make decisions get to make them and put them in place immediately. And I think that was an example of something working really well. A disengaged administrator that I have seen wanted to change culture, had all of the best intentions, was getting the money put into culture changing trainings for the whole staff. But guess who wasn't on the roster for those trainings? That jail administrator. So we can't just train the frontline staff. We have to embody the concepts of what we're training to our staff, and then we can model and demonstrate what that culture is supposed to look like. if your top administrator, your health services administrator have a strong belief that reducing the amount of time someone is isolated is going to have long-term positive outcomes with their clients, then that's going to very easily translate to the frontline staff to know that this is a priority. I have to make sure that a certain amount of rec time is permitted, or give an opportunity for someone to not be in isolation as much as they might have wanted. So it goes. It's not just top down, but it's inside and out.
And I
Fred,
can tell
anything to
you,
add?
yeah, thank you. I actually, a personal failure of mine, I don't want to say sometimes people have big egos in these positions. I may have had one myself. And I can tell you that one of the transitions that I had the last probably 5 to 10 years of my career with the Las Vegas Metropolitan Police Department, when I was running the jail, I thought I was working effectively with medical and mental health care. And I'll never forget this. I had the medical director said, "Hey, you guys really need to watch. You're using the restraint chair an awful lot. People are dying across the country." And this is probably a decade ago now. But people are dying from this, right? Yeah, you know what? I told our training's good. It's not going to happen, this and that. And, my personal failure was I didn't take that to heart as quickly as I should have. And we actually did have someone that ended up passing away. No, none of the officers did anything wrong. Let me put that out there 100%. They were all operating according to policy. But if I had put my ego aside and really, listen to understand, maybe instead of listen to respond, there's the potential that it could have changed policy and practice sooner and potentially saved a life. I don't know, but I can tell you this. The experts with medical and mental health have knowledge that is just not trained into correctional leaders, right? There is to some degree, a little bit, but they have expertise that on the custody side, we just don't have. It's extraordinarily valuable to you because I can tell you, for those folks that are running large institutions, your job lives and dies on the success of your operation. And when human lives are involved and you have these experts that have been through, an ungodly amount of training and have a great amount of experience, it's incredibly important that you take that to heart. And that's why it's so important. And really, it led to me becoming really engaged with medical and mental health care, and now coming into the position that I am, because it will literally save lives. And one of those things too, there is a challenge sometimes because there is so much scrutiny with jail operations, right? And it's so hard. People come in and the officers have a lot of oversight. And as terrible as it sounds, that oversight is critically important because human nature is when you're doing something over and over and over, that complacency is going to happen. It's human nature, right? And that's one of the reasons why it's so critical to keep suicide prevention and this interdisciplinary collaboration at the forefront, because if you focus on something, you'll get improvement for a few months. If you fail to focus on it, guess what? It's going to go back to that homeostatic level where it's not where it needs to be. And I've seen, many, many facilities and even in my own, I've seen officers, lose their jobs sometimes, not because they were trying to be malicious or anything, but just because of complacency. And so that's why it's so critical to keep these things really on the front burner. And when there are accountability measures in place, it's not because you're trying to pick on anyone or not because you're trying to get anybody in trouble. That's where supervisory engagement comes in. Hey, was just checking the video, whatever, this or that, to protect the officer and protect those people that are in custody, so we can make sure if we're going by and doing our checks on inmates that are on some kind of watch, or even just going through and doing checks in the middle of the night, right, which can be monotonous. If you're going there and you're checking for signs of life and everything's on video, so remember, there's Monday morning quarterbacking everywhere. It helps to ensure that folks are going and not only protecting the people that are in custody, but protecting themselves and the organization, so we can ensure that, hey, those people that are in our care, custody, and control, we're giving them every opportunity to succeed. And again, you will never stop everything bad from happening in a jail. It's just not going to happen. However, if leadership and the boots on the ground recognizes that, hey, this is our mission, this is our goal, that not only all of us go home safe healthy at the end of the shift, that these people going back in the community are going back in as good of shape as they can. So anyway, that's get off my soapbox.
Yeah. So solid observations, Fred. Thank you so much. And let's transition from leadership and culture and talk a little bit more about something that Dr. Brinkman brought up, and that's policies and procedures. So, let's talk about some of the more impactful things from your perspectives that a jail can do to mitigate risk, around intake screening, detox protocols, and such.
Mhm. Well, I would like to say from my perspective on intake screenings, I know every facility is going to have a different amount of resources available to them. That is absolutely for sure. But when you're able to really carve out the resources to do in-depth mental health screenings at the front in intake, it's a game changer in trying to get those incarcerated individuals started on their medications, into the treatment that they need to be in the facility. I know when a lot of people are working toward the standards for accreditation, it's really easy to allow the nurse to do those initial screenings that are required for standards. If you partner that nurse up with someone who is from a mental health, qualified mental health professional, to be able to do their portion of the screening, then when we talk about force multipliers, that's really going to put your treatment and path to treatment light years ahead of facilities who need to wait through that referral process. The nurse finds it, they refer to mental health professional. Professional assesses it, they refer to psychiatry. But if mental health professional is able to identify that from the get-go, that early on, then that's when you really get further faster in stabilizing these incarcerated individuals coming in some kind of crisis. And let's face it, when our patients are living on their own in whatever state that is, they tend to not take their medications because they've felt better for a little while. So they're likely not on their medicines when they come back to us at jail. So the faster we get them back to that psychiatrist to get them on the therapeutic levels that they need to be on, the faster that you'll see stability in the jail, and not just in a mental health unit, but your officers will have the ability to manage any housing unit a little bit better when people are feeling better. They're less irritable. And let's be honest, that's like number one symptom for almost any mental health disorder is irritability. So it's the start of your operation for us.
Dr. Brinkman, would you mind talking? One of the things that we've found across the nation is that there's really kind of a high risk time. So if people come in and they're put on suicide watch, it seems like when they come off, that period there for a couple of weeks and then following them throughout the rest of their incarceration can be a challenge and really high risk times for them. Can you kind of talk about what might benefit facilities when someone is, so they come in, they're identified, they're actually put on suicide watch. When they're coming off suicide watch, what is a good thing to ensure that your jail is doing to reduce your risk and ensure they get the treatment that they need?
Well, like I said earlier, the crisis might be over, but the problems aren't. So once they are stabilized from that suicide watch, they could be just reporting safety purely from the fact that they don't want to be on suicide watch anymore. It may not actually be that they feel stable. So we want to make sure that we don't just do one follow-up. It has to be progressive, because especially if this was a suicide watch that came from intake, those first weeks of incarceration are some of your most volatile for an incarcerated person. And the more that they've acclimated to the culture within the jail, could be positive, could be negative, and it could be more stressful for them. So we've got longer away from their connections, longer away from the things that they usually use to manage their symptoms. So we need to be able to check in with them at multiple points in time and really treat it like you would see a mental health system in the community, because let's face it, our our courts are slower than they used to be. People are staying longer in jail, so they're experiencing those symptoms going haywire for a longer amount of time. We need to have a connection, not just the next day after we're discharged from suicide watch, but maintain some of that observation for a little bit and then start to step them down before we evaluate if general population is appropriate. And I know that's one of the biggest struggles for many facilities is that basically residential space is limited. You have a certain algebraic expression for which population can live together, how many housing units you have, how you can put people in different places. But if you're able to dedicate some of your space to that acute level of care, some subacute, and then something that is more of a high functioning mental health population before they go out to general population, it gives them this opportunity to really work on the coping skills that they need before they get into general population, where all bets are off. Life is just different. Things are less controlled. And that's when we want to make sure that we still maintain some kind of contact. The rule of thumb in community mental health care is typically once every 90 days on the outside of the normal limits. That's someone who's really highly functioning, is if you're meeting with them that frequently or that infrequently. If they are still fresh to admission and still working on those skills, we need to be seeing them more frequently, just like we would if they weren't in jail.
One of the things that we've seen, and I just would like to get your feedback on this. So some of the facilities I work with, and again, this is one of those things where it's almost like the inspect what you expect. And I've seen some more collaboration with the custody leadership and the officers and everybody else in talking about policies and procedures. Some of the successes that we've seen, because that issue can really be a challenge when policy for medical and mental health may actually be contradictory to some of the custody policies, right? And it seems like those things kind of get pushed to the wayside. But when you get both of those together, custody, medical, mental health, to make sure their policies are in line with their goals in the process to get to those goals, that we see some success. And I'm just throwing this out there. I'm not saying that this is what any facility should do. It's just this one came to mind. They had gotten together and for their particular facility, what they decided was when someone comes off of suicide watch, they will be seen the next day by mental health again. If they're still doing well, they're seen in 7 days and then 14 and 30 days. And then it kind of goes from there. And that's just an example of when you got folks at all levels, right? So when you're doing policy, it should absolutely not be the administrator that's saying this is what we're going to do. You should have input from the folks that are working boots on the ground, right? You're going to have nursing there. You're going to have officers, supervision, management, everybody working together to identify what the best practice is for your facility, things like that. Have you experienced that process elsewhere? And is that an effective way to kind of come up with what really the best way to manage like suicide step downs, things like that?
Personally, I do find it to be really effective. The only caveat to that, I would say, are those patients that everyone wants to label behavioral. That's a behavioral, but they weren't really suicidal. But something I like to encourage and remind our healthcare professionals, if you weren't in jail, you probably wouldn't call them behavioral. You would probably see it as a sign or a symptom of some type of behavioral health problem. So behavioral doesn't mean that it's just manipulative and we don't respond. It just means we don't know what the need that behavior problem was trying to say is not being met. So in those instances for the incarcerated individuals who may not be depressed, they may not have a high lethality, they still need an increase in care. It doesn't mean that they need suicide watch. It just means that they're going to need something from the behavioral health system within the jail. In those instances, I have seen that the 1 day, 3 day, 6 day, 13, 1 month feels like overkill, but I think when that is being said, it's not looked at in the same way. Just because we're not at risk of suicide doesn't mean we're not in need of some kind of care. So the care that we need at that 1 day, 3 day, 6 day, 13 a month is different, but it's still needed in order to reduce those behavioral problems that we all say exist in the jail, because that is likely going to translate into other poor choices that are going to potentially get them in segregated housing, disciplinary, maybe administrative custody. If we're able to manage those earlier, we won't see as many problems or as frequent problems in those areas of our jail, and potentially not backlog our housing system of, oh, I don't have enough mental health beds. I don't have enough discipline beds. I have to put mental health and discipline together, which we would love to not see. But it's solving a different problem, but it's still solving a problem within the jail.
Well, thank you, Fred and Dr. Brinkman, for lending your expertise to this important topic. We're running out of time. I did want to give you an opportunity to touch upon anything that you wish we'd spent a little more time on, or just for some closing remarks. And Fred, we'll start with you.
Sure. Well, thank you so much for this opportunity, Chris, and thanks to the American Jail Association. I love this podcast idea. I love that information is going out and we're getting so much engagement around topics like this, because as someone who's been in the field since the mid-90s, I've seen so many changes. It's such a challenge to work in the field for custody, for medical, for mental health. And what an outstanding group of people. And you know, as I said, there's no industry that's perfect. You're always going to have a small minority of individuals that maybe are not appropriate for the profession. However, the vast majority, I would say, are the unsung heroes of both the justice system as well as the medical and mental health system. You have people that are working with, managing, providing treatment for some of the most challenging folks in our population overall. And, you know, I know that I could speak for Dr. Brinkman that it's our honor to work with people and really try to identify some gaps and fill those gaps to reduce risk and provide better care. And then hopefully a better community in the end, because, you know, while we have the walls, it's certainly not just an isolated environment, right? Everybody's coming back to the community. It's our honor to work with everyone, and just thank you for the opportunity. And certainly if I can ever be of assistance, if you ever have any questions, if you can't find the document that we referenced about the suicide prevention manual, please feel free to reach out to me anytime. I'll be happy to assist. So thank you.
I know I'm really excited for the opportunity for us to have conversations like this, because I alluded to it earlier, but there's not enough of us, whether it's a correctional professional or a healthcare correctional professional. And the more we talk about this and the more that it becomes more mainstream, so to speak, the more people might think, wow, if I really want to see the most interesting in healthcare, I'm going to go to a jail. I'm going to go work in jail if I want to be challenged in my medical career. And I think that these kinds of opportunities not only are important conversations to have, but it needs to become a second nature, that we understand that this is a core part of our community, and we need to have more conversations like this publicly.
Well, thank you again. And for our viewers, thank you for joining us for this very important discussion. And you can continue the conversation, by the way, via iConnect, which is AJA's online discussion forums. Both of our subject matter experts have access to it and can answer any questions that might come to mind as a result of today's conversation. So thanks for joining us, and see you next episode.
Thanks.
Thank you.